Hello, everyone, and welcome to session number 2 of the first day of American Kidney Fund Kidney Action Week. Today, we have several sessions, 3 altogether. This is our second session titled Hypertension, Diabetes, and Kidney Disease and Understanding the Connection. I am Melanie Paris, and I am Senior Director of Health Initiatives and Education here at American Kidney Fund. I will be your moderator today, and I'm very, very pleased that we have 3 expert doctors to discuss the connection between high blood pressure, hypertension, diabetes, and kidney disease. And it's our hope that at the end of this session, you will be able to understand more about the connection between these 3 conditions, but also tips on what you can do to keep yourself healthy and manage the conditions if you have them. Before we begin, I would like to take a moment to thank No Diabetes by Heart Alliance. No Diabetes by Heart is a joint initiative of the American Heart Association and the American Diabetes Association with the goal of raising awareness of the link between diabetes and heart disease to prevent cardiovascular deaths, heart attacks, and strokes among people living with type 2 diabetes. American Kidney is also a proud member of this initiative, and we hope to bring awareness of how cardiovascular disease and diabetes affects your kidneys. So for more information, you can take a look at the link about the alliance, the nodiabetesbyheart.org. Now, I am honored to introduce you to our distinguished panel of doctors, each of whom have dedicated their work to these 3 respective conditions: cardiovascular disease, diabetes, and heart disease. So first, we have Dr. Neha Pagidipati. She is an assistant professor of medicine and cardiology and cardiometabolic disease prevention at Duke University. Since 2011, she has conducted research on cardiometabolic disease prevention, lifestyle modification, and weight management. She is currently a National Institutes of Health K-12 scholar in implementation and dissemination science. Additionally, Dr. Pagidipati directs the Cardiometabolic Prevention Program at Duke University Clinical Research Institute, which focuses on behavior change and risk factor modification in patients with high risk of cardiovascular disease and metabolic diseases. Welcome, Dr. Pagidipati. So glad to have you here. Next, we have Dr. Samuel Dagogo-Jack. Dr. Jack is the A.C. Mullins Endowed Professor and Chief of the Division of Endocrinology, Diabetes, and Metabolism at the University of Tennessee Health Science Center in Memphis. His current research interests include the interaction of genetic and environmental factors in the prediction and prevention of prediabetes, diabetes, and its complications. Thank you so much for joining us, Dr. Jack. And rounding out our panel for this session is Dr. Pablo Garcia. Dr. Garcia is a nephrologist who is currently at Stanford University, where he is focusing on transplant nephrology. Dr. Garcia is also one of American Kidney Fund's very distinguished clinical scientists and nephrology fellows. His professional interests are also in global health related to kidney disease and also the effect of COVID-19 on patients on dialysis. So throughout our conversation today, we will be answering your questions. So please type your questions and comments into the window next to or below the Facebook Live video stream, and we'll try to answer as many questions as we can. So before we get into audience question, I have one question for our panelists about their background and why they decided to get into this. But before we get into that, what I would like to do for our audience is just give a very quick high-level overview of the effect of kidney disease, diabetes, and heart disease, and how that interplays all together. Could I have
Well, maybe I should go first.
well, just a moment. I think we have a slide on that, so I don't see it up yet. That's okay. Just one moment, I'll bring it up. Oh, here it is. Thanks. So this is just to give the audience that we have, just some background on what this combination of diseases really is all about. So A lot of people don't realize, and I know our whole panel does, that diabetes is the leading cause of kidney disease, and more than 34 million people in the United States have diabetes. So that's about 1 in 10 people. High blood pressure, hypertension is the second leading cause of kidney disease. And people living with type 2 diabetes, chronic kidney disease, are 3 times more likely to die of a cardiovascular event compared to people with just diabetes alone. And what happens, diabetes puts stress on both the heart and the kidneys. And over time, this stress leads to, or can lead to, heart disease and or kidney failure. But there are medications for diabetes that can now improve heart and kidney health. And although damage to the kidneys from kidney disease can't be reversed with proper eating and often with medication, it may be possible to keep the damage from getting worse and slow down the progression. So just wanted to give some background for our audience about why we're even having this discussion and why it's so important to enlighten people as to the connection between all of these. So first, I will go back to Dr. Jack. Can you tell our audience, one, how you got into endocrinology, and could you give a little background on what an endocrinologist does?
Thank you, Melanie. Endocrinology is the branch of medicine that specializes in the diagnosis, evaluation, and management of people with glandular and hormonal disorders. It's an extremely broad field that addresses glandular elements literally from head to toe. And increasingly, we've added obesity and osteoporosis, bone disorders, reproductive issues into the specialty. But nothing in the field comes close to the burden we face from diabetes. So most endocrinologists practice, or a good component of their practice involves people with diabetes. I got in the field during my residency training in England, a place called Newcastle upon Tyne, when one of my faculty members impressed me and basically inspired me to follow her into the specialty. Then I relocated to the US and trained additionally, completing my fellowship in endocrinology, diabetes and metabolism at Washington University School of Medicine, stayed on faculty for about 10 years and then was recruited away to my present position in Memphis, the University of Tennessee.
Thank you very much. How about next, Dr. Garcia? Tell us about what the role of a nephrologist is and how you got into the profession.
Thank you, Melanie. So first of all, I became interested in nephrology. It goes back to when I was in Guatemala. While I was speaking with patients with kidney disease, I realized how difficult it was for them and also their families to deal with the kidney disease. I became very interested in learning more about the kidney disease and ways to prevent it. Then, when I moved to the United States to pursue further training, I also noticed the burden of kidney disease among the patients and their family. So then I decided to become a nephrologist. And what is the job of a nephrologist? We spend time in the clinic and inside the hospital. We have the opportunity to take care of patients with early stages of kidney disease, more advanced kidney disease, and acute kidney disease. The main goal is to determine the cause of and prevent the progression of kidney disease. When we care for patients with advanced kidney disease, our primary goal is to help them improve their quality of life by providing them the best therapy available. As transplant nephrologists, we evaluate patients before they get a kidney transplant. We optimize their health as much as possible so they are ready to get a kidney transplant. And after the kidney transplant, we support them to keep the kidney working as long as possible.
Thank you, Dr. Garcia. I will go to you next, Dr. Pagidipati. Tell us about what the role of a cardiologist is and how you chose this as your specialty.
Thank you so much. So a cardiologist, very simply, is somebody who is focused on helping take care of disorders of the heart. But it's actually not just the heart, it's actually the vascular system, the blood vessels throughout the body still kind of fall into the domain of a cardiologist. But generally, we are focused on things having to do with the heart and risk factors that influence the health of the heart, including diabetes, high blood pressure, kidney disease, and so on. And I became a cardiologist because at a relatively young age, right after college, I spent a lot of time in developing countries, specifically in Tanzania and India. And I went expecting to find a lot of malnutrition. And instead, what I found was an increasing amount of overnutrition and obesity and cardiovascular disease. And I realized that if I want to have an impact on a large population of people, especially in underserved populations, I really need to focus on how to prevent heart disease. And so that is how I became a cardiologist, and I love it.
Thank you for that. So I'll just stay with you on, as we get into some questions that I have before we get into some that are coming in from our audience. Dr. Pagidipati, can talk to us about what the connection is between hypertension, high blood pressure, and kidney disease. How does this affect one's kidneys?
It's an excellent question, and I can't state enough, and I think my colleagues will probably agree, how interconnected these disease processes are, or how interconnected the health of your blood vessels and what your blood pressure is, how interconnected that is with the health of your kidney. And it turns out that high blood pressure can cause kidney disease, and kidney disease can lead to high blood pressure, and it can get into this vicious cycle. And it's incredibly important to understand that when you have high blood pressure, it doesn't, it affects everything. It affects the blood vessels in your brain, the blood vessels in your kidneys, the blood vessels in your heart, the blood vessels in the rest of your body. And so it's incredibly important to understand as a patient that all of these things are interconnected. So when you think about, for example, managing your own blood pressure, it isn't just a number that you're trying to lower and get in range. That's just the beginning of it. You're really protecting your kidneys when you control your blood pressure, and protecting your heart and protecting your brain. And so it's a really important thing to understand that, because sometimes, if we can't feel our high blood pressure, and for most people they can't, it can feel like it's not a big deal, or I don't need to address it, or I don't really need medication. But the reality is that even if you can't feel what's going on, something's happening in your blood vessels. And in order to protect all of your organs and your overall health, you really need to manage your blood pressure.
Thank you for that. It's so important. So from your perspective, Dr. Jack, we know that diabetes is the #1 cause of kidney disease. So can you talk to our audience about the connection between diabetes and kidney disease?
Sure. Over their lifetime, 2 out of every 5 patients with diabetes would suffer significant kidney damage. Many would have the disease progressive to the point where they would need serious intervention for end-stage kidney disease. And over the years, as we succeeded in keeping people with diabetes alive through modern medications and comprehensive care, the longer they lived, the more we discovered that there were several complications that they could develop. And one of those is the kidney disease. And upon researching further, we have observed numerous risk factors, which when added to diabetes, portend great ill for kidney health. So you have the blood pressure. 70% plus of our patients with diabetes would have high blood pressure over their lifetime, and poorly controlled blood pressure would collude with the diabetes itself, the sugar damage, to exacerbate kidney risk. We have issues such as dietary preferences, and when the hypertension doctor or the kidney doctor advises patients to limit the amount of salt intake, we do the same in the diabetes clinic, because excessive consumption of certain foods, high calories, high salt, fat-dense diets actually are bad for vascular health, bad for glucose regulation, bad for blood pressure. Excessive weight gain or carrying too much weight also is a risk factor. So we have a landmark study called the Diabetes Control and Complications Trial that was conducted between 1983 and 1993 that gave us the silver bullet to show that if the blood glucose is controlled to goal and the hemoglobin A1C is kept at or below 7% over several years, there was a significant dividend to be realized in terms of prevention of complications in the kidney, prevention of complications in the eyes, and prevention of nerve damage. More recently, we've also now discovered additional interventions that would even decrease the risk for heart disease, heart failure, and stroke. So all in all, diabetes is a fellow traveler with hypertension, high cholesterol, and together they cause increased risk of damage to the heart, blood vessels, and kidney.
Thank you so much. I mean, those two connections, high blood pressure, diabetes, it's so good to understand now what the connection is between that and kidney disease. So speaking of kidney disease, Dr. Garcia, so the CDC reports that 96% of people are living with kidney disease but don't know it. That's a pretty astonishing number. Can you tell us why that is?
Yes, I think this is a very interesting question and very important as well. The main challenge is that people with chronic kidney disease may not feel it or notice any symptoms. So the only way to find out when someone has kidney disease is through specific blood and urine tests. And I think one of the main barriers is that access to healthcare is one of the main issues here in the United States. So a lot of people, or a large proportion of patients, they only find out that they have kidney disease only when it's advanced and they have to go to the hospital. And unfortunately, they have to probably start treatment with renal replacement therapy or dialysis. So I think from a public health perspective, more resources could be allocated to increase the public awareness about the disease. Advanced programs targeted towards prevention and early detection is very important. So activities such as this one that we are having right now with American Kidney Fund are very important to try to share some of what we know to the patients and family members, friends, so that way they can do something about it and perhaps look for a physician or a healthcare provider that can order some of these tests that are not very expensive, but sometimes getting to the clinic is very challenging. Getting to the lab is very challenging. So we can do better as healthcare providers as well.
Thank you for that. So going to you, Dr. Pagidipati, so the CDC also estimates that about 1 in 3 adults have high blood pressure, and that 75 million who have it are unaware that they have it, or they are not controlling it. So what steps should people take to improve their outcomes with high blood pressure?
It's an excellent question. And I think the first step towards managing your blood pressure is knowing that blood pressure is important and knowing what your blood pressure is. So if you ask me what is the most important thing that somebody can take away from this, if they're not already thinking about their blood pressure, is to please go get your blood pressure checked. And it doesn't have to be at your doctor's office. It could be at your doctor's office, and it would be great if you are getting regular checkups. But let's say you're busy, you've got multiple jobs, you're doing this, you're doing that, and you don't have a lot of time. You could go to your grocery store, your nearest pharmacy, and get your blood pressure checked. And there are certain ways to do it, and all of that's important, and it's easy to kind of go online to the American Heart Association's website and just look at how you should check your blood pressure. But at the end of the day, it's incredibly important for every single person, every single adult, even anybody over the age of 18 years old, to know what their blood pressure is. And if your top number, your systolic, is above 130, or your bottom number is consistently above 80, that is higher than we would like it to be, and you need to see your healthcare provider.
So just a quick follow-up to what you were saying, how often should someone check their blood pressure if they know they have hypertension, and if they don't have hypertension, they've never been diagnosed with it, how often should those two categories of individuals be checking their high blood or for their blood pressure?
It's an excellent question, and there's no kind of one size fits all or one answer for everyone, even within those two groups. So, for somebody who has high blood pressure, it depends. If your blood pressure is not well controlled, then you need to be checking it more often. And then, if it's out of control, you need to be talking to your doctor about it. So, I will have patients, for example, who are coming to me, and I'll start them on a new medication for their blood pressure, and I'll have them check their blood pressure once a day at various times of the day, just not right after exercise. But check their blood pressure once a day for a week or 2 weeks and email it to me. And that blood pressure log helps me understand what their blood pressure is like at home and helps me adjust their medications. There are other people who have high blood pressure, but it's extremely well controlled and they don't need to check it on a regular basis. We just check it when they come to the office. The same is true for people who don't have a history of high blood pressure. You should check it at least a few times. If you've never checked it before, check it at least 2 to 3 times on different days just to see generally where things are, because your blood pressure will vary based on how stressed you are, what you've just done. Did you just run in from the outside? Your blood pressure will vary. And so you want to get an average over a few kind of time points. And if it's consistently above 130 on the top or 80 on the bottom, then that's something you want to see your provider about. But there isn't, to your question, there isn't kind of a specific number of times you should be checking it for every person.
Well, you did offer a very good tip in your explanation there. Keep a log so that you can keep track of your blood pressure's been over a period of time. That's very important. Dr. Jack, so what are some signs of diabetic kidney disease?
Well, the short answer is there are none. And that's why the NIH and CDC and other authoritative bodies are announcing that the vast majority of folks with kidney disease are not aware of it. So one wishes that kidney disease were like migraine that would alert the individual with some disturbing pain and make them take action. Kidney disease joins the group of silent killers, as is diabetes. And you notice I'm wearing the ADA red shirt to recognize the participation and collaboration of the American Diabetes Association with the National Kidney Foundation for today's awareness event. I served as president of the ADA in 2015, and the ADA is the single loudest advocacy voice that speaks for the welfare and well-being of people with diabetes. And kidney disease and diabetes is so prevalent and so preventable that what we have done is to add to our annual guidelines, the standards of care for medical practice, which is published in January of every year in the leading journal, Diabetes Care. We programmed into the standards of care a mandatory proactive screening strategy to look for the early markers of kidney disease. And every qualified doctor who practices to guidelines and takes care of people with diabetes is aware or should be aware of the need to check for the amount of albumin protein that is spilled in the urine for every gram of creatinine that is excreted. It's a simple test that is ordered from the spot urine sample obtained during the office visit. We also are now adding the estimation of the glomerular filtration. So as we produce urine, the process involves filtration from the blood, keeping the good blood cells and so on in the blood, and then getting the urine and the urea and the waste products out in the urine. That filtration process is vital to survival. And the function or capability of the filtration declines in certain disease states, and early declines are a marker of failing kidney function. That test can now be programmed into routine blood tests, and the lab will calculate the estimated GFR, glomerular filtration rate. So what I would ask the audience to note is that if they are not getting feedback from their physicians during their regular office visits for diabetes care regarding what their urine albumin spillage rate is, or what their estimated glomerular filtration rate. I know these are tongue twisters, but just urine protein would cover that. And then kidney function. How are my kidneys doing, doctor? That could trigger appropriate guidelines-directed care. And the doctor may have ordered the test, but neglected to share the information. I ask my patients to carry a little notebook with them, just as they record their blood sugars when they test them at home. When the doctor gives them information about kidney, A1C, urine protein, they should write those down. And that reminds them to ask how they are doing. It's absolutely important not to wait for symptoms before you go looking for help regarding your kidney function.
And that is key. Don't wait for symptoms. Because again, as we mentioned, a lot of people who are living with kidney disease in those early stages may not realize it. So let me transition into that question, kind of more on that with you, Dr. Garcia. So people, as you mentioned earlier, unfortunately often find that they have kidney disease once it's in the very late stages, when they start to feel symptoms. Oftentimes also, people find out that they're at a very stage of kidney disease just from routine blood work or a urine test with their primary care doctor, perhaps. At what point should someone be referred to a nephrologist if they have shown some reduced kidney function?
Yes. Oftentimes, we will like the patients with kidney disease to be referred to a nephrologist when they have we measure the kidney function by measuring the creatinine, which is a marker in the blood, and then we do an equation, and then we determine the glomerular filtration rate based off of this, and we have an idea what is the kidney function of one patient. So we usually recommend the patient to be referred to a nephrologist when the EGFR, which is this glomerular filtration rate, is less than 60. And the main idea of doing this is that we can understand better when it's early stages of kidney disease rather than being late. So this way we can investigate, we can find out what is the main issue, what is the problem, and sometimes we can find solutions, or at least we can prevent the fast progression of kidney disease. And then something else that we can do is we can do a urine test to measure for protein, and this will give us an idea as well. Some people might have good kidney function when we measure the creatinine, but we start noticing some degree of kidney dysfunction by looking at the urine. Usually in the urine, we don't expect protein, but then when we find some protein in the urine in someone that maybe has diabetes, for example, that can give us an idea of what is the kidney function and what are the kidneys doing and what can we do to help. So those are the main tests that I will recommend. One is a blood test and the other one is a urine test.
You need both of those, correct?
Yes, both of those.
Well, thank you all so much. We have some great questions coming in from our audience. I want to start with a question from Angela. So let's see, I will pose this to you, Dr. Pagidipati. This question from Angela is, do you have high blood pressure first, or is that caused by kidney issues? And a follow-up about diabetes says, I've had diabetes my whole life and never really talked to anyone about kidney disease and how my diabetes could be affecting my kidneys. Is this normal? And I'm thinking the question is it normal to have not talked to anyone about the connection? But maybe we'll go back to the blood pressure first. Does high blood pressure happen first, or is the kidney issues causing high blood pressure?
It's an excellent question, Angela. Thank you so much for this question. So very often people will have high blood pressure first, and for various reasons, and I'm sure Dr. Garcia could go into more detail, for various reasons, that is basically toxic to the kidneys. It is not good for the blood vessels in the kidney and for the kidney tissue to have very high blood pressure. And so it can cause kidney damage, the high blood pressure. That being said, there are a lot of hormones involved in this. And as people get worsening kidney disease, that can also in turn worsen blood pressure. And so it is, as I mentioned, kind of a vicious cycle where one can worsen the other. But in my mind, I tend to, as a cardiologist, I will tend to see people with a high blood pressure first, who then over time, especially if it's not controlled, start to develop kidney disease, either for that reason or because of diabetes or some other reason. So I'd be interested to hear what my colleagues think as well. But briefly around your question of the link between diabetes and kidney disease and not having talked to your doctor about it. Unfortunately, that's incredibly common. You're not alone, and don't feel badly that you haven't had that conversation. I think the goal of all of us here today is to empower you and others to begin to have those conversations with your providers. And it's not your provider's fault. Your provider has your best interest at heart, but there are a lot of things going on in a day in clinic. And so, unless sometimes if you don't bring it up, sometimes that's not the top of thing, the thing that's top of mind. But it is very, it's not uncommon at all to have somebody not ask those questions or not think about that connection. And that's really why we're here today, is to help people think about that connection between the heart, diabetes, and the kidneys.
Absolutely. Thank you for that. I'll pose this one to you. Let's see, we have another question, I guess for everyone. So question from Renee is, how connected is hypertension and diabetes to the thyroid? What lab tests should patients monitor, what lab values should patients monitor to stay on track?
I guess that's for the endocrinologist. Right, so thyroid diseases are not as common as diabetes, but in certain age groups, between ages 30 and 50, for women, you have overactive thyroid, hyperthyroidism, prevalent to about 10-15%. And in the older age group, 60 or older, underactive thyroid hypothyroidism begins to again rise in prevalence. Both overactive thyroid and underactive thyroid may be associated with modest alterations in blood pressure, usually 5-10 points sometimes in the upper number, the systolic. And the role of diabetes and thyroid on changing the blood pressure numbers has not been very thoroughly studied, but there are situations, particularly in type 1 diabetes, which, as you would recall, is a less common form that tends to affect younger children and younger individuals. In that disease, occasionally in some families, people would inherit the risks for both type 1 diabetes and for thyroid disease. And the combined effects might again shift the blood pressure numbers upward. But by and large, high blood pressure tends to be on its own. Doctors use the term essential hypertension because we often cannot find what is triggering it, except that it tends to run in families. But then when you have diabetes, the risks are much higher to have hypertension. Like I mentioned earlier, more than 70% of our people with diabetes also harbor elevated blood pressures.
Well, a couple more questions since I have you, Dr. Jack, about diabetes. Then I have a couple questions about EGFR that I want to pose to Dr. Garcia. So Dr. Jack, quick, is diabetes hereditary?
Yes, it is hereditary, but the pattern of genetic hereditary is not like the way you inherit eye color from your parents or something. In the medical field, we use the term Mendelian genetics, that is dominant traits. You tend to look like your parents in broad general sense. But diabetes is inherited as a multigenic, polygenic disorder. So in a given family, for instance, even when dad and mom have diabetes and say are blessed with 4 children, rarely would all 4 children come down with diabetes. So the pattern of transmission is more complex than the simple Mendelian genetics. Nonetheless, we like to generalize by saying that having a close family member with type 2 diabetes, the more prevalent form of diabetes, increases your risk of developing diabetes about 2-fold compared to somebody without a close family member with diabetes.
And one more about diabetes that came through. If you are pre-diabetic, can you reverse it so you don't become diabetic?
Excellent question. That is where the field is headed right now. And just 2-3 weeks ago, I published an entire textbook on pre-diabetes. You can find that on Amazon by Googling it. We want to make sure that we practice smart medicine in the field of diabetes. And there is now overwhelming evidence that nobody really goes to sleep with perfect blood sugar and wakes up the next morning with type 2 diabetes. Instead, people who develop type 2 diabetes inch their way there gradually and pass through this intermediate stage, which we now know and call prediabetes. And that prediabetes state can be diagnosed by certain blood sugar numbers. And people may spend upwards of 10 years, 5 to 10 years in that state before diabetes occurs. So the full-blown diabetes experience can be prevented if you noticed somebody at the stage of prediabetes. And the good news is that we have published in the US Diabetes Prevention Program that the interventions needed to prevent progression from pre-diabetes to type 2 diabetes are not draconian. They are modest adjustments in what you eat and how you choose to spend your leisure time, increasing physical activity by some modest amounts and reducing certain high-fat, high-calorie diets and maintaining a healthy lifestyle. So you do not necessarily need medication in the pre-diabetic state. In fact, no drug is yet approved to treat individuals with pre-diabetes because of the powerful and well-demonstrated effect of lifestyle adjustments in warding off the future risk of diabetes if you currently have pre-diabetes. And one final word. Pre-diabetes, again, just like kidney disease, has no symptoms. You don't urinate excessively. You don't feel any differently. Therefore, only by proactive screening and testing for the blood sugar can your doctor help define your status of pre-diabetes and begin to help you by sending you to a dietitian and counseling you to change your lifestyle habits toward a healthier pattern.
And thank you for closing with that. That's key. Having regular checkups so that you know your health status is important. Dr. Garcia, so here's some questions about EGFR. For our audience, maybe some of you don't know, Dr. Garcia, if you want to expand on that, please. The EGFR is kind of the measurement that doctors use to determine how well your kidneys are working. There's a number given so that you know. One question that we have is, could having diabetes or hypertension cause your EGFR to drop from 45 to 10 in just a couple of weeks? And kind of a follow-up, it's related. Can you increase your GFR if you have diabetes or kidney disease? And if so, how?
Okay, perfect. I think that those are very, very good questions. I think that the first one, can having hypertension and or diabetes can drop your EGFR from 45 to 10. When there is an abrupt drop in EGFR, usually we are thinking about something that is that is causing the kidney disease at that moment, and it's something acute. And I think that it will require more investigation. Usually we don't see that drop from 45 to 10 with diabetes and hypertension in just 2 weeks. There perhaps something else going on, and it's not just diabetes and hypertension. When we see that as nephrologists, and we look at the kidneys with an ultrasound, and we see that the kidneys have like a good size, or at least we are able to do a kidney biopsy, we might go ahead and offer this to the patient to investigate, take a look at the tissue with a microscope and determine what's going on with the kidneys, because that is very abrupt drop. And then going to the other point is, when we have kidney disease, when we have diabetes, and can we increase the EGFR? It is important to understand that the EGFR might fluctuate with some of the medications, but it's not going to just to answer the question, no, it won't increase, but perhaps we are going to decrease the progression of kidney disease. And going back to this point, I wanna just mention this, which is very important. We have probably two main windows of opportunities when we are looking at the kidney function and EGFR. One is when the kidney function is reduced, we can prevent the fast progression. And two, when when the kidney function is advanced, we can always refer a patient when the EGFR is less or equal than 20 to a transplant nephrology center, and they can get the patient and they can evaluate the patient for getting a kidney transplant. And this is very important because the patient gets to the center and the EGFR is less or equal than 20, the patient start getting some time in the waiting list. And this is very important. Unfortunately, some patients don't know when they have kidney disease, and they get a little bit late to the healthcare system, and that's when they start accumulating some time. So EGFR is very important to help as much as we can.
Well, I'm glad you mentioned that, because we did have a couple of questions about at what point one should be able to get on the transplant list. So one question was, I'm at CKD stage 4 in both kidneys. When should I get on the transplant list? And at what GFR should I go on dialysis?
Okay.
I think you mentioned some of that.
I think, yes. So I think that EGFR less or equal than 20 will automatically qualify the patient to get evaluated at a transplant center. So I think this is probably one of the most important questions here in this panel today. And sometimes the nephrologist is going to refer the patient, but sometimes the patient can always ask the nephrologist to refer them to a center, transplant center. They can go to multiple centers if they want. And this is when the EGFR is less than 20. And then I think that when we are talking about sorry, I just want to verify, what was the next question?
Stage 4, when to get on the transplant list? Or yes. What level to go on dialysis?
Correct. So the next question is when to go on dialysis. Usually we don't have a specific level when we go on dialysis. So the EGFR can be as low as 5 or as low as 10. And it all depends on the symptoms. Sometimes people with kidney disease or advanced kidney disease might develop some symptoms which are related to the toxin accumulating in the body, or sometimes the potassium can be very high, or on other occasions, or very often we see patients that we're just not able to control the fluid in their bodies, meaning that they probably cannot handle enough water, salt, and we might need to start dialysis because of those reasons. It's probably not related to the number. I will say that lower than 10 is the number that we have to just watch for these signs and these symptoms, and then we will decide. The main idea is to keep the patient of dialysis as much as possible, but also to keep them comfortable and safe.
Thank you. So just a reminder to our audience, during this week, we do have a session on the transplant process and also living at stage 3 kidney disease. So you probably would want to join those sessions as well and get some additional questions answered. I have some questions about blood pressure for you, Dr. Pagidipati, sorry about that. Let's see. So one is, for controlling high blood pressure, how do you know if the medicine that is being prescribed is best for you? And I'll just have a quick follow-up. What time of day is the best time of day to check your blood pressure?
Okay, so In terms of knowing what type of blood pressure medication is best for you, that's really a conversation that's best had with your provider, whether that's your primary care doctor, cardiologist, or whoever it is that is managing your blood pressure and prescribing medications for you. They can help you understand which type of blood pressure medication you can be on. And the reason I say that is because there isn't just one, there are many blood pressure medications, and there are several different classes of medications. And depending on your specific case, what other kind of health issues you may have, or what allergies you may have, and so forth, it depends. The doctor will tailor, or the provider will tailor their advice and their prescription just for you and your specific situation. So it's hard to say there's one type of medication that's better for another. It really depends on your personal situation. For example, there are some medications for blood pressure that are also very protective for your kidneys and your heart, especially if you have diabetes. So if I have a patient with diabetes, I want to make sure that especially if they have high blood pressure, and especially if they have any evidence of kidney disease, I'm treating them with an ACE inhibitor, a type of medication called an ACE inhibitor or an angiotensin receptor blocker. That's just an example where I tailor my prescription to what the patient needs. In terms of the second question, what time of day, I'd be interested to hear what everybody else says. I tend to I'm a pragmatist. I like to keep things as simple as possible for patients and for myself. And so I don't tell people a specific time of day to check their blood pressure. As long as they check their blood pressure once a day, that's fine. Because I'm trying to get a general sense. It doesn't have to be perfect, and I'm not looking at one number. So the really important thing to keep in mind here is I'm looking at the average of many numbers. I'm looking at a log of over 1 to several weeks. And so any one number may be a little bit off, but I get a general sense of where your blood pressure is. And so I don't have people check it at a particular time of day. It also depends on when they're taking their medications and things. So I just say, just check it, because then at least it's more likely to get done. The one thing I will say is don't check it right after you exercise, because then it may be kind of spuriously high. But other than that, I tend to be a bit low key about that.
So this question is about medicine. And recently there have been some studies showing that there are medications that are both protective of diabetes, heart disease, and kidneys all at once. So I'll start with you, Dr. Pagidipati, since we're already speaking. Can you tell our audience about, some of those medications, how they work, how they can talk to their doctors about those?
Absolutely. And so we have actually, it's like an embarrassment of riches in the last few years, actually. In the last several years, less than 10 years, really, a number of medications have come to market that, just as you said, are good at lowering your sugar levels and good at sometimes at lowering weight. But that's not all they do. Some of them also help your kidneys. Some of them can help prevent heart failure. Some of them can help prevent heart attacks and strokes and death in general. So we're coming into an era where there are medications that don't just do one thing. They do a lot of things that are really good for you. And so it's important for you to have an understanding of what those are and have a conversation with your provider about whether or not those types of medications are right for you, because they're not right for everybody. And it needs to be tailored to your specific case. So one of those classes of medications is called SGLT2 inhibitors. And I know that's a mouthful, but SGLT2 inhibitors, examples of those, and there are many examples, but empagliflozin, dapagliflozin, canagliflozin, erdagliflozin. Again, these are really long and complicated names. But if you just remember to talk to your doctor about the newer medications that help people with, and even sometimes without diabetes, and protecting their heart and their kidneys, your doctors will probably know what that's called. The other class of medications that are very exciting are called GLP-1 receptor agonists. And those are medications like semaglutide, dulaglutide, liraglutide, and others. They have also been shown to be very beneficial in patients with type 2 diabetes in preventing heart disease, and to some degree in preventing kidney disease as well.
Dr. Jack, Dr. Garcia, would you like to have any comments also on some medications that are out now that can have just tremendous outcomes for people who have diabetes, heart disease, and also kidney disease, and slowing down progression of kidney disease and protecting against heart?
Sure. These newer medications are providing tremendous optimism for concurrently controlling blood sugar whilst reducing the risks of kidney damage or progression of pre-existing kidney damage. Some of them have been so inspiring that trials have been conducted in people who do not even have diabetes, but simply had heart failure or kidney disease. And the results are exactly the same. The caveat is that these studies proved their effects or efficacy in carefully controlled clinical trials in which there were prescribed inclusion and exclusion criteria in terms of people who were admitted into the study and exposed to the medication compared to placebo. And those may not be applicable to any and all comers. And that's why the practicing physician must update his or her knowledge and follow the guidelines, because the impact of these medications has already been captured in the updated guidelines from the American Diabetes Association. And it is very important and laudable that the American Kidney Fund is holding these educational events directed directly at the end user or consumer, the patient himself or herself, so she can jot down some of these factors to take and open up a conversation during their next visit to their doctors.
Dr. Garcia?
I think Dr. Pagidipati gave an excellent summary of the medications. The only thing that I would like to add is that in the past, in the past probably 20 years, we as nephrologists, we weren't able to offer a lot of medication to prevent progression. And now we are very excited, and we feel that this is going to change a lot the way that we care of the patients with chronic kidney disease. And as Dr. Dagogo was mentioning, this medication might even help those patients without kidney disease, with diabetic kidney disease. And I think that is excellent. We'll see. There are ongoing trials on this topic, and we will see what happens in the future. But definitely, we are very excited about these new therapies.
So I have a question, and I know that all of you will say very. The question is, how important is what you eat in controlling chronic kidney disease and some of the related conditions? Before you answer, I want to remind everyone that we have several sessions about kidney disease and have dietitians on many of those sessions. So please check our agenda. And then Thursday, we also have a whole session on Thursday at 2:30 with the cooking doc. He is a nephrologist who also cooks. So if you want more information about what to eat, you can also check some of our resources, but I will go back to you. Let's start with you, Dr. Pagidipati. How important is what you're eating in controlling chronic kidney disease?
Incredibly important. I think it's incredibly important for basically all of the processes that we're talking about, not just kidney disease, but diabetes, high blood pressure, heart disease. These are all, as we're saying, interconnected things. And what you eat impacts all of these things. And so understanding what's right for you, given your specific set of conditions, is incredibly important. So talking to your provider about this is important. But, for example, for people with high blood pressure, following something called the DASH diet, DASH diet. If you Google it, there's information all over the internet. The DASH diet is basically a common sense diet that is high in vegetables and fiber and lean proteins, and it's low in all the bad stuff. It's low in junk food and processed foods and red meats, and it's also low in salt. And there's kind of a version of it that's low in salt that's also very good for lowering blood pressure. So these are things where if a person follows the DASH diet, that will often give them as much blood pressure and lowering as one medication. So what we're saying essentially is the DASH diet, if I were to prescribe it to you, is as effective as a medicine. And for a lot of people, if they can follow something like the DASH diet, they might be able to decrease the number of medications that they're on. And that's just one example in hypertension. There are other examples in diabetes and so forth. But what you eat is incredibly important for basically every aspect of your health.
Dr. Jack.
I would concur with what has just been expressed, but also simplify the message by saying that healthy eating trumps all. So you may not even need to pursue any specific named diet, but after you visited with your dietitian and increase your knowledge by reading and visiting credible websites like diabetes.org, the American Diabetes Association website, and the AKF and all of the other websites, you will notice that healthy eating has components that reduce saturated fat, excessive calories, excessive salt, and promotes water-dense fruits and vegetables, along with healthy lifestyle, physical activity, and that keeps the weight down. Because keeping the weight down also improves blood pressure, blood glucose, the risk of kidney disease, heart disease, and many others. So healthy eating as a lifestyle cannot be overemphasized.
Well, thank you so much. We just have so many questions. I wish we could get to them all, but the final question that I have in our last 3 minutes for all of you, if you want our audience to go away with anything from this session, what's maybe 1 or 2 things that you want them to take away from this?
I would say that do not wait for you to feel symptoms or get sick before going to your doctor. Diabetes and hypertension affect nearly half of the adult population and are the leading causes of kidney damage. Therefore, ask to be tested and know your numbers.
Dr. Pagidipati.
I would completely agree. I think I had 2 major points, and that was one of them. Know your risk factors, know your numbers, your blood pressure, your sugars, your kidney function. Know where you stand, because that's the first step to addressing things. And the second thing is what we were just discussing. No matter who you are, no matter what kind of comorbidities you have, eating a healthy diet and exercising every day will help to prevent badness. No matter who you are, what you have, blood pressure issues, kidney issues, diabetes, heart disease, exercise and healthy eating will help everything. And so without that, you're at a disadvantage. And with that, you and your family have an advantage to live a longer, healthier life.
Dr. Garcia.
Yes. So I think that kidney disease can be very challenging and confusing as well for patients and their families. Understanding all this stuff about EGFR, creatinine, protein in the urine, etc. It's very confusing. And I think that the main message is that we are here to support you. The healthcare providers working in nephrology are here to support you. So whenever you have any questions, or even if you're going to visit a nephrologist, ask all the questions. And I think that we are here just to help. And sometimes it's so nice when we see a patient and the patient asks like all these very relevant questions, and is going to make a huge change. And to sometimes just to make some small adjustments. And by asking questions to a provider, you might reach that.
Thank you so much. So we have some key takeaways. We'll put up on a slide for you so that you can just have a visual. So just wrapping up too, high blood pressure, diabetes, kidney disease, they're all very closely linked. And in order to prevent one of them, there's steps that can be taken to control all of them. There are medications now to improve heart and kidney health. If you have kidney disease, monitoring and controlling your blood pressure and blood sugar are vital to slowing down progression or even preventing it if you don't already have kidney disease. If you have high blood pressure, diabetes, please talk to your doctor about getting a blood test and urine test to check your kidneys, because as we mentioned, very often you don't recognize symptoms, and please work with your doctor to come up with a treatment plan. So happy that everybody was able to join us. I want to thank Diabetes by Heart, or No Diabetes by Heart, for this wonderful session. Please join us at 3 o'clock for our next one on clinical trials. We also have resources for all of your questions.